My name is Sarah Rylance and I'm a consultant paediatrician. In this short presentation, I'm going to share with you the results of some research we've been doing in Malawi to try and improve asthma care by reallocating various aspects of asthma management from doctors to non-medical staff. I'm passionate about improving asthma care in resource-limited settings such as Malawi. It has been the focus of both my clinical work and my research over these past 3 years. But why should we care about asthma? Asthma is the most common chronic medical condition in children. Untreated asthma can lead to severe asthma attacks and even death. According to the Global Asthma Network estimates, worldwide 1,000 people die every day due to asthma. Asthma symptoms of coughing, wheezing and difficulty breathing cause young people to miss school and their families to take time off work to care for them, which has costs for the family and wider community. But importantly, asthma is treatable, and with the appropriate inhaler treatment, children with asthma can lead normal, unrestricted lives. Most people have heard of asthma, but what exactly do we mean when we talk about it? Asthma is chronic inflammation of the airways in the lungs, which causes chest tightness, coughing, wheezing, or shortness of breath. You see inflammation on the surface of your skin following an insect bite, and the redness and swelling and irritation of inflammation are also found inside the lungs of a person with asthma. Typically, asthma symptoms come and go, and children might have particular triggers which make their asthma worse, such as viral infections, smoke and fumes, exercise, dust, or changes in the weather. These triggers irritate the lungs and cause bronchoconstriction or tightening of the muscles around the airways. A combination of swelling due to inflammation and tightening of these small muscles cause the airways to become narrowed, which restricts the movement of air in and out of the lungs. Asthma treatment needs to target both these problems, both bronchoconstriction and inflammation. Global asthma guidelines recommend that asthma is treated in a stepwise fashion, with a bronchodilator inhaler such as salbutamol, which is used when the child has cough, wheeze or difficulty in breathing, to open up the airways and relieve the symptoms, and a steroid inhaler such as beclomethasone, which is used regularly to reduce inflammation and prevent attacks. Both types of inhalers should be used with a spacer device to improve drug delivery into the lungs. These inhalers are also the current recommended treatment for asthma in the Malawi Standard Treatment Guidelines, along with education for the family on how and when to use the inhalers correctly and what to do in an asthma attack. Our research was conducted at Queen Elizabeth Central Hospital, which is a government-run tertiary level health facility. At Queen's, asthmatic children are seen in the general paediatric clinic, along with children with a variety of other conditions. It is a busy, unstructured environment, and it's challenging for doctors to spend the time they would wish to assess asthma control and provide education to the child and family. With that in mind, we designed an asthma care package which could be delivered by non-physicians and compared this to standard care in clinic in a randomised controlled trial including 120 children. The enhanced care package included 3 components. Firstly, objective assessment of symptoms and airflow obstruction. This was measured by the Childhood Asthma Control Test, or CACT, and spirometry. Secondly, we optimised inhaler treatment according to a standard protocol, with inhaled corticosteroid treatment started or increased if the CACT suggested poor symptom control or spirometry suggested acute airway obstruction. And thirdly, we included asthma education in the form of a 1-hour individual session based around an asthma action plan. These activities were conducted by field workers, Emma, Hygiene, Malumbo and Bright, who are in the centre of the photo. They were employed at Malawi Liverpool Wellcome Trust. They have no previous medical training, but received structured training on asthma from me before the study started. Their daily work was supervised by Beatrice Chinoko on the left, and she is a senior research nurse, and I was available to provide senior medical advice if needed. Our research questions were: can asthma outcomes be improved through an enhanced care package as compared to standard care in the paediatric clinic at Queen's? Can asthma education be delivered effectively by non-clinical staff, in other words lay educators? And is eosinophilic airway inflammation prevalent among Malawian asthmatic children? And this last point is important to determine whether the recommended use of inhaled corticosteroid treatment, which has been extrapolated from high-income settings, is appropriate for children in Malawi. Between September 2018 and December 2019, we recruited 120 children from the General Paediatric Clinic at Queen's. All children aged 6 to 15 years with a doctor diagnosis of asthma were invited to join the study. Children were randomised to either continue with standard care in the general clinic or receive the enhanced care package intervention, with outcomes measured at 3 months. At the end of the trial period, those children who had been allocated to standard care were offered the chance to receive the intervention. The primary outcome was the Childhood Asthma Control Test score, or CACT. This is a 7-item questionnaire. The first 4 questions, which use a pictorial scale, are for the child, and the last 3 questions are for their parent or carer. The final score is out of 27, with a higher score reflecting fewer asthma symptoms and better control. The CAT has been validated elsewhere, but not in Malawi, and we forward and back translated and then piloted the questionnaire in clinic before the study began. As secondary outcomes, we also asked about asthma-related healthcare use and school absence, and measured lung function and exhaled nitric oxide, or FeNO, which is a marker of airway inflammation. Beyond the trial analysis, we collected questionnaire data and measured lung function and FeNO for all of the participants who received enhanced care, both before and after the intervention. So to start with the baseline results, the average age of our participants was just under 10 years, and 2/3 of them were boys. In the previous 3 months, 1/4 had been admitted to hospital due to their asthma, and additionally another third had attended health facility but not needed admission. 2/3 of children had missed school due to their asthma, and the mean CACT score was 20 out of 27. Comparing enhanced and standard care, both groups had similar baseline characteristics. This table shows the difference in asthma outcomes between the 2 groups at 3-month follow-up. Statistically significant differences are highlighted in the table in green. Children receiving the intervention had better asthma control, less emergency healthcare use, and less school absence compared to those in standard care. Lung function and FeNO levels were similar for both of the groups. And for both groups, FeNO levels were generally high, which is defined as greater than 35 parts per billion, with a normal or low FeNO level being less than 20. These graphs show the change in GINA score, and this is a symptom score recommended by the Global Initiative for Asthma. Patients are categorised as having well-controlled, partly controlled, or uncontrolled asthma, depending on how many positive responses they give to the 4 questions listed in the green box. The graph on the left shows the number of children in each GINA category at baseline, and on the right for 3 months. Standard care is shown in dark grey and enhanced care in light grey. So for standard care, the dark grey columns, the pattern of control is similar in both graphs. But for enhanced care, the light grey columns, we can see that the number of children with uncontrolled asthma decreased and the number with well-controlled asthma increased at 3 months. We also conducted a qualitative sub-study led by Lovemore and Kalamba to explore the experiences of those involved with the asthma education sessions. These are just a couple of illustrative quotes. Parents wanted to know more about asthma and before the study didn't know what to do when their child became unwell other than to go to hospital when things were really bad. Participants really appreciated the education sessions and reported increased asthma knowledge and confidence to manage symptoms at home. So what are the conclusions we can draw from our study? We found a considerable burden of symptoms among asthmatic children attending outpatient follow-up at Queen's, with roughly 2/3 of children having sought emergency healthcare and missed school due to their asthma in the preceding 3 months. The intervention had a significant impact on asthma outcomes. Those receiving the enhanced care package had improved asthma control, and emergency healthcare use and school absence decreased by roughly 70%. FeNO levels were generally high, which suggests that eosinophilic airway inflammation is prevalent and that inhaled steroids are appropriate treatment in this population. Our qualitative sub-study found that it was both feasible and acceptable to use lay educators to deliver asthma education, and that this approach was greatly appreciated by the families. And so where do we go from here? This study was done in a tertiary level health facility with a relatively short follow-up period. The results are promising, and the next steps will be to test this approach across a wider range of settings and potentially include other non-communicable diseases. Children and their parents frequently report difficulty in obtaining inhalers, particularly in primary care, where salbutamol tablets are widely used. We need to improve access to inhalers and increase awareness among clinical staff to ensure that children are receiving the most appropriate and effective treatment for their asthma. Many of the parents involved with the study are keen to raise asthma awareness in their local communities and are planning to form a peer support group. Empowerment of patients and their families is a really important step to improving asthma management and quality of life. We have shown that improved asthma outcomes are possible with minimal resources, but appropriate use of inhaled medication and education of children and families is crucial to realise these benefits. I would like to thank the many people who have helped to make this project a success, and thank you for taking the time to listen. The final slide has some information and references relating to the trial for those who are interested. Thank you.